Well, good morning, everyone, and welcome to the second meeting of the workforce subgroup of the Kansas Senior Care Task Force. I'm your facilitator today, Carrie Bernier. I'm the Vice President for Policy at the Kansas Health Institute. As mentioned in our previous meeting, Hina Shah, one of my colleagues, will be the primary facilitator for this working group, but covering for her as she's out for a couple of weeks, but she'll be back for your next meeting. I have the agenda, or I will have the agenda up here in a moment as soon as I start sharing my screen. Let's see. You see that pretty well? This is the today's agenda. We have a couple new content experts who have, there we go. A couple new content experts who have joined the task force or the working group as members of the working group, and then we're going to have a presentation also from one of the subject matter experts and one of your colleagues that's on the working group as well today. So we'll go through and do some introductions. We just have 90 minutes and we have a lot to get through today. So I'm going to scroll down to our meeting commitments. Remember to come ready to discuss and compromise. Mostly today it's going to be discussing. We're not going to be setting up any recommendations yet, but we will be reviewing some of the recommendations that members of the task force have discussed that were referred to the workforce subgroup. We want to keep remarks succinct and on topic, but don't hesitate to ask clarifying questions, and we commit to start and end on time. So with that, I'm going to stop sharing and then go ahead and have folks introduce themselves. So I'd like to ask basically each of you to just say your name, your organization, and last time we asked, what do you wish to accomplish? But maybe something you've learned since the last time we've met that you really that you think would need to be important to be discussed in the workforce working group. If you don't have anything, that's okay too, especially the first person always gets put on the spot to have to answer that question, right? And then we'll save for last our two new content expert members, and we'll have them do a little bit of extra introduction. So I'll let Kelly and Christina know that we're going to ask sort of a broader question, like what would you like to see this group accomplish? And what would you like to see accomplished when you think about the workforce for older adults in Kansas? So you've got a few minutes to think about that. But Haley, I'll start with you, and everyone can do self-introductions. A reminder to always, when you speak, to say your name and your organization, because folks are watching us on YouTube and on Harmony, and they need to have an opportunity to know who's talking. So take it away, Haley.
All right, good morning. My name is Haley Ordin. I am the representative with the Kansas Adult Care Executives, and I am co-chair here. Excited for that for the work group, for the workforce. I think all of this is so vital. So excited to be here once again. Let's see, something I've learned. I've learned a lot, so much already. Probably the biggest thing that I think is underrated in the whole scheme of things is how much the trauma from the pandemic is affecting the workforce right now, and how unaddressed that issue is, and how key I think that's really going to be for the continuation of this industry. I'll leave it at that.
Thanks. The next person I see is Deborah.
I'm Deborah Zaire, President and CEO of Leading Age Kansas. And I'm glad to be on this group. I think I would echo what Haley said about it really has come to light for the members of this group, I think, the trauma to long-term care workers across settings, and the need to address the workforce crisis, which is now at epic proportions. Thank you.
Thank you, Deborah. Dan.
Good morning, Dan Goodman. I'm the Assistant Commissioner of Long-Term Supports and Services for KDAS, and what have I learned? I'm really new, so hopefully you'll give me a little bit of a pass on this since it's my first official meeting. But I kind of agree with somebody said just earlier about the impact the pandemic has on the workforce and how that's causing issues on just meeting residents' needs on a daily basis. So.
Thanks, Dan. Camille.
Well, I just got signed in, so I didn't hear the question. Can you repeat it for me?
Oh, no worries. It's just anything maybe you've learned or thought about since the last time this group met that you'd like to share sort of in context, to set up the context for today.
All right, thank you. Camille Russell, State Long-Term Care Ombudsman. I appreciate that. As I was kind of hearing and we were kind of talking about workforce issues, obviously that is an emergent issue. I just want to make sure that we are not looking at fixes for an emergent issue differently than what we should. We're partly having an emergent issue because we needed to fix longer term issues prior to the pandemic. And so that's something I hope we're looking at that as a focus of what's really good ongoing.
Thank you. Ernie.
Thank you, Carrie. Ernie Cutzley, AARP Kansas Advocacy Director. I just wanted to say thanks for everyone that's on this call and on the task force, because I think in looking back at all we've done so far in the discussions and presentations, it's really fantastic to bring together this kind of expertise and to look at long-term care challenges and staffing and all the other issues. So I thank everyone for their participation. Thank you.
Thanks, Ernie. Jamie.
Amy Gideon with the Alzheimer's Association. Mostly I've learned everything that I've been hearing about workforce for quite a while now, just the profound impact it has had on the residents of the long-term care facilities. And it's just, it's definitely tough to see. So the more we can do to fix this long-term, I agree with Camille, the better. Thank you.
Great. Thanks, Jamie. Leigh.
Morning. I'm Leigh Chaffee. I work at Brewster in Topeka, Kansas, and I'm representing adult care homes across the state on this task force. I think the thing that I have learned or really has become apparent is that it is going to be very difficult to move forward with any of the wonderful initiatives that we want to have for seniors without the human capital to do it. So, and that's not only the quantity of people, but the quality of people to carry out what we feel is best for seniors in Kansas, or what truly is best for seniors in Kansas. So I think that's what I've learned. The human capital is going to be the foundation of anything that we do or want to do moving forward.
Thank you. Okay, I'm looking for other folks. Shawn.
Good morning, Shawn Sullivan. I'm the president and CEO of Midland Care, senior services provider in Northeast Kansas. I think I agree with Leigh. So I've been thinking a lot about the effect of the pandemic on the workforce and our ability to provide services. I think there's varying levels of, I don't know if you call it desperation or exasperation of those of us that are in the provider community. And I think it's only worsening. And I know that the pandemic worsened, as some of you have said, an already tight labor situation. I'm interested in some capacity with whatever means are available, seeing whatever data is out there. And I don't know there is, as to the reasons folks have left the workforce and made a bad situation worse.
Thanks. Okay, so now we've given a little extra time to Kelly and Christina to help answer our questions. But Haley, I don't know, did you want to say anything to introduce Kelly and Christina, or sort of why we were thinking that these are two new content expert members of the working group? So these are folks who can help with some of the, obviously with the content, but whose expertise and background will really help the discussions. And they actually are part of the working group, as opposed to some of the other subject matter experts, like some from KDADS, one from KDADS we'll hear from this morning, but who will help answer specific questions. They'll be able to be here for the full context. And Shawn is one of the content experts, and now Christina and Kelly are joining us too. But Haley, did you want to add anything else?
Just the only thing I'll add is welcome, first off, and happy to have you guys here. The thought behind bringing you guys on board was I will let them speak for themselves for their knowledge and area, but I think that they are going to be huge assets for representing people within the workforce and giving them a voice. You know, what better means to go to than the people that work in the industry to figure out the workforce crisis, and also to understand the process and procedures of what we already have in place so that we don't waste time reinventing the wheel, because quite honestly, as I think we're all very well understanding, we don't have the time to waste to serve the workforce and those that we serve through the workforce, the elders that we care for. So time is of an essence. We want to bring everyone on board to see what we can do immediately and then what our long-term goals are so that we can shift and pivot the issues that we're presenting right now. So be happy to let them further introduce themselves.
Great. Well, Christina, do you want to go first?
Certainly. My name is Christina Rudisol. I am the Director of Practical Nursing and Health Occupations with Johnson County Community College. And I have known that this workforce issue has been an issue for quite some time. We've actually been dealing with it. So I'm excited to be here and honored to be considered for this. My big goals, what I would love to see is, I agree with the need for human capital, and something that we've been struggling with for literally years is being able to train that human capital. And I can go into detail when appropriate on why that's such an issue. But we simply do not have enough nurses to train the CNAs to get them into the workforce. So that's a legislative issue that we need to work on. Living wages is another issue that I hear from CNAs all the time, is that they can make more money doing easier work. So that would be another thing that I would love to see. And I think overall, I'm really excited that this is being addressed at this level now. But I think the pandemic has just really brought to light and exacerbated a problem that was already there. So, but I'm looking forward to working on this and helping in any way that I can. So thank you for the opportunity.
Thank you, Christina. And Kelly?
Hi, everyone. My name is Kelly Summers. I'm a BSN RN and director of the Kansas State Nurses Association. I appreciate being asked to be a part of this task force because I'm sure you're doing amazing work. I'd like to echo probably every single thing that Christina just said, and really look at future. And really, we knew this was a problem a long time ago. COVID has exacerbated things. I talked to nurses who work in long-term care all over the state, including those who would keep working there and those who have left, to provide any additional information. I have data to show what we had already anticipated in a nursing shortage by 2030, which has now been accelerated by COVID. And these are many, many issues that need to be addressed now. A lot of it may be outside of the task force. I'm not sure, but they're always something that I could put forward for additional conversations. So thank you so much.
Thanks, Kelly. Did I miss anyone? I will say that Harris from the Kansas Legislative Research Department and Emma Urich from KHI are also on the call. So, and I think Charles is still on too from the Legislative Office of Information Services. So if you have any questions about the technology, you can direct those in the chat to him. But otherwise, I think we're ready to go. So appreciate that. That's really good context. So I will let you know that we are still working with have reached out to and are still working with folks at the University of Kansas Medical Center to identify one of the folks that you talked about potentially that could be helpful to join as a content expert would be a behavioral health provider who who will understand the context of behavioral health needs of the workforce as well as of older adults. So, and that may be one or two people, depending upon who gets nominated for our next meeting. So look forward to another member joining you. So right now, I'm going to hand it over to Brad Ridley and Dan Goodman, both from KDADS. In one of our previous meetings, in our preparation meeting with the co-chairs, Haley and Senator Holscher, one of the questions that they thought would be helpful, and in our previous meeting we discussed a little bit, is to understand the rate setting process for providers who provide care for older adults, both in long-term care facilities, in at home and community-based services, behavioral health, et cetera. And that's important information that will also help for those of you who are on Working Group B, who are looking at rebalancing. I think that's important to understand too. But as we'll see when we go through some of the referred recommendations for this working group, there's discussion about rate setting for direct service providers and how important that is. We've talked a little bit this morning about and funding and support for wages for those frontline staff. So with that, I'm going to hand it over to Brad Ridley and Dan Goodman. I don't know if you guys are going to tag team, or Brad, if you're going to present from the Department for Aging and Disability Services. Take it away. And we can share your screen, Brad, whenever you'd like us to.
Okay, great. So I am Brad Ridley, Director of Operations at the Kansas Department for Aging and Disability Services, KDADS, as Carrie said. So here this morning to walk you through our rate process for both the frail elderly waiver and our nursing facility program. And Dan, do you want to introduce yourself before I get started?
Oh, muted.
Dan Goodman, Assistant Commissioner for Long-Term Supports and Services, KDADS.
So Carrie, I'll probably start with the HCBS frail elderly waiver. And do you want me to share the document, or do you have it? You all have it to share on the screen? We'll probably start with the other HCBS rate. Perfect. So what you see in front of you is a list of our HCBS frail elderly waiver services. So I think most of you all probably know, but just to recap, our HCBS program is for individuals in the community, receive in-home supports, community supports, to keep them out of institutional care. So this is a list of those services that are available to individuals who meet those qualifications for the HCBS frail elderly program. So this gives you an idea of what the rates have been starting in FY17 to current. The current rates that are on there today are rates that were in place in last adjusted in fiscal year 20 and had remained the same since fiscal year 20. So that's our current rates today. And I should have included on this list the unit frequency, because these are rates paid on a billing a unit frequency. I don't have that, but the vast majority of these services, especially around the personal care and the comprehensive support services, are a 15-minute unit. So taking that into account when you think of what the hourly amount would be, those are 15-minute unit rates. So these rates are set. There isn't an annual or a reoccurring time where these rates are updated. It's based on budget and appropriation from the legislature on how these rates are adjusted over time. So really no methodology in place other than they can be adjusted based on appropriation within the budget. So any questions here on the FE rates?
Yeah, this is Christina with Johnson County. I need clarity. I'm not familiar with this at all. Could you please educate me on, are these rates that KDADS provides the facility, or is it rates that the KDADS provides the resident or patient?
So these are provider rates. So these are the rates the provider would bill Medicaid for these services provided. And so just to give some context as well, these services are all in a managed care environment. So we have 3 managed care organizations that we pay a capitated rate to, and they turn around and pay the providers. So these rates that are set by the state are the floor, considered the floor rates for managed care. So an MCO, as they contract with providers, can pay them more than these rates, but these are the state set rates are the minimum that has to be, we require to be paid by the MCO to the provider.
Thank you for that clarity.
Sure.
Brad, this is Haley. Can I ask a question of you also?
You bet.
Okay, so again, for clarification, I just want to make sure I'm understanding these rates are set by legislation. There's no methodology calculation of prior expenses or anything. And is it automatically adjusted every year, or did you say the last time was 2020 and then it's just based on what legislation allocates for? I just want to make sure I understand that.
So
correct.
the last adjustment to the FE rates was FY20. And there, we have 7 waiver programs, these HCBS programs. In 17, 18, and 19, I believe the legislature did increases across the board, across all 7 of the programs. In some years, they may target specific services or specific waivers, but this is kind of what our experience has been for the FE waiver. And so I think to answer your other question is no, there's not a annual set amount. It's based on what does get appropriated by the legislature at the end of the day.
Okay, and is this based off of fiscal year starting in July, so that if there were recommendations this session, the rate wouldn't take place until next July?
Typically, that's how it works. There has been cases, I think even last year, there were some increases the legislature added for the IDD program that they did make effective May. So we did have to do some adjustments for May, June. But typically, these are July 1 fiscal year start effective dates.
Okay, thank you.
This is Ernie from AARP. Can you go back to the 15-minute, excuse me, 15-minute, and you mentioned 15 minutes for something, and I missed that. I'm sorry.
Yes. Yeah. The rates for personal care, comprehensive support are 15-minute unit rates. So for every 15 minutes billed, that is the rate that is paid.
Thank you.
And so, Carrie, we might flip to the other FE document, and I can talk about the proposed rates that we have submitted in budget for fiscal year 23. Great. So, talking about the budget process and the appropriation process, this year in the KDAT's budget that was submitted to the governor, we did put in an enhancement request to make adjustments to all of our personal care related rates for all of our 7 HCBS programs. And that proposal was accepted by the governor. And when the governor released her budget last week, did include this as part of her budget. So at this point, the governor's budget does include these rate increases for the services identified before for that FE waiver program. And the couple main things as part of this enhancement request that the agency put together, the focus was on standardizing rates across the 7 programs. So we had personal care rates that were different for most of our different programs. So we had gotten a lot of feedback that was, that inequity was problematic. So step number 1 in this proposal was to standardize those. And then once they're standardized, so they're equal across the 7 programs, then we added 2%. So you'll see the personal care services for FE are proposed at a 2% increase because they were already the highest across the waivers. But the self-directed personal care was lower than some of the other waiver. So it was standardized and then 2% was added. So that ended up being the proposed increase there is about 11.6% increase for the self-directed services. So this today is what's in the governor's budget pending approval by the legislature. That would be effective for fiscal year 23, which will start July 1 of this year.
Brad, I have a question if I may.
Sure.
So I kind of want to make sure that believe I understand that. So we would be looking at for individuals who are in a state licensed facilities receiving HCBS services and these in the different waivers, that those are all those would be all paid at an agency directed rate instead of self-directed. So this would encourage in some extent the ability for people to self-direct in their homes. And have a more standard, rate of pay. And also we have experienced it in recent years where we have had state providers that have decided they will not serve a particular waiver recipient because it's just a few cents, just these few cents difference sometimes that they receive less for one waiver than another. So thank you for looking at making those be more standard.
Sure. And one thing I'd add based on that comment, Camille, is when you look at personal care services level 3, that is the rate that is paid for individuals in a state licensed facility, such as an assisted living facility. So that personal care level 3 is specific to individuals living in a state licensed only facility, such as a assisted living facility.
Quick question, Shawn from Midland Care. Hey, Brad, a couple questions. One, what's the prevalence of self-directed care on the frail elderly waiver? It's something that we're starting to pilot within the PACE program to allow our participants to pay a family member to self-direct their own care to help us address a workforce issue. Is that being done on this particular system or waiver? And then second, you made a comment when you were going through the previous slide about the rates set by the legislature are the floor to the managed care companies. Can you talk a little bit more about that? Why would a managed care company pay more than the floor as it relates to how they're reimbursed?
Sure. So the first question, Shawn, remind me what your first question was. I already forgot.
How prevalent is the self-directed care and that for elderly waiver, and is that an opportunity to grow that?
Yeah, so self-directed, and I'd have to do some digging on the numbers, but I think it historically has been around 50 to 55% of individuals that choose to self-direct. And basically what that means for everyone is the individual basically acts as their own employer, and they can hire individuals and pay at the self-directed rates and determine how they get their services from these workers. So they act as the employer in this situation. So I think what we're seeing too is that there is going to and has been more emphasis on growing that self-directed opportunity, especially given the workforce. If there's some more opportunity for folks to receive those services, self-directed as opposed to agency directed when there's some staffing challenges around that. Your second question, Shawn, about the floor rates. So when we set these rates as a state, again, it's, we say MCO, you must at a minimum pay these rates to providers, and that's what's factored into their capitated rates that the state pays to the MCOs. Now, an MCO can choose to pay above these rates. For some examples of why that might happen is if they do any kind of pay for performance initiatives where they may pay a higher rate if certain quality criteria are met. We know that happens in the managed care world, as opposed to just say contracting, what they might have to pay to contract a provider. That provider may only contract at a certain rate. So Those are a couple examples of why an MCO may contract at a rate above what we consider the fee for service floor. Any other questions on the HCBS rates? And I might add too, as we were talking about self-directed, you'll see the service, it's financial management services. That's the rate. It's a monthly rate per person that is paid to basically a payroll agent that assists with making payroll for those individuals choosing to self-direct. In the case where the customer is acting as the employer, so they use that financial management service as the payroll agent there. If there's no other questions on the frail elderly waiver, we can shift to nursing facility. And so I will kind of hit the nursing facility rate setting process at a high level. And Dan, feel free to jump in and add anything I may miss or anything you want to make sure we hit on here. So before I get into this chart, I'll kind of just give a general overview of the rate setting process for nursing facilities. So nursing facilities annually receive an individual rate. So each nursing facility has a unique rate that is based on their specific costs. So every nursing facility in the state every year sends a cost report to the agency, to KDADS. And that cost report is reviewed and potentially audited and is used to set a facility specific rates. The agency uses a base period of 3 years of cost reports and has going back to 2009 and even beyond that. So those 3 base year cost reports are basically averaged together to determine a rate for each facility. So what this chart shows you is the history of what those rates have looked like, what the basis has been for the cost report years and the methodologies associated. So in column 1, obviously the fiscal year, column 2 is the base cost report period, that the 3 cost report years that were used in that fiscal year to set the rate. There's also an inflation factor that is added where inflation is adjusted as much as possible, with the target being inflation to the midpoint of the fiscal years for which we're setting a rate. The 4th column there is what the average rate across all of our nursing facilities has been each year. And the next 4 columns are cost center limits. As part of the overall process, there are limits set on indirect healthcare, direct healthcare, and real and personal property fees and operating costs, which are based on medians across all the cost reports from all the facilities. So medians are set and there's cost limits based on that. On the last few columns here, there's an adjustment to the rates for case mix, CMI, case mix index, and we can see each year what that case mix adjustment was across the nursing facility. So there's that adjustment that's always made for acuity in the rates as well. The last 2 columns address cost coverage based on the reported costs of the facilities. This would show what overall costs are covered by the rate. The agency usually in that process really wants to see, we want to see over 90% as a target of that overall cost coverage. So that's a very high level overview of the process, but essentially very different from HCBS as it is an annual process that's based on cost reports. The thing I do want to add here is that it is subject to appropriation. So every spring when we get cost reports in, cost reports are due by the end of February. There's a very intense process to go through and get proposed rates set, start looking at different scenarios and methodologies, determining which 3 cost report periods we will be able to use and what our options are based on the appropriation from the legislature. So that's really the overall process. So every spring we have scenarios based on what we believe that budget will look like. And we work with our stakeholders, nursing facility stakeholders, to really determine based on that appropriation what the best methodology is in which cost report base period you use and what the inflation looks like within that appropriation. So I'll stop there and see if there's any questions. And Dan, was there anything you wanted to add at this point?
Just that the other thing that we also do is the case mix adjustments every 6 months, and I think you may have touched on that a little bit. But
yeah, so rates are adjusted. Initial rates are set July 1 and adjusted in January for adjustments to case mix.
This is Haley again. If I might ask a couple questions. This is Haley Ordin with Kansas Adult Care Executives. I believe I've got 3 main questions. My first one would be if you could explain a little bit more the inflation midpoint of how that is determined, trying to be as basic as possible. And I know that is probably a hard request because there's a lot that goes into it. The second is not so much an opinion, but trying to understand this from just the facts. I know that a big concern that we often hear with the base cost data period is that it seems as if, take for example, this year for calculating, as you show on the very bottom, we're using rates and expenses that are, 4 years antiquated in time frames. So it seems as if to providers, our reimbursement rates are already 4 years behind, and we're taking, some averages of those expenses. And especially right now with pandemic, with cost of goods, with products, everything, XYZ, our costs that we're getting reimbursed for now were from 3-4 years back. And so it feels like we're already behind the curve there. I'll let you answer those 2, and then I'll ask one more at the end if you don't mind.
Sure. So talking about inflation. So inflation, what I would call more ideal scenario would be if we looked at the most 3 recent years of cost, and then tried to inflate those costs to what inflation would be to the midpoint of the fiscal year. So let's say we're looking at fiscal year 23 rates. Ideally, we would adjust inflation to the midpoint of that year on top of the 3-year base period cost. So we're saying in that case, we'd be looking at, if we were talking at perfect scenario for FY23, we'd be looking at 19, 20, and 21 costs, and then adjusting inflation to December of 22. So what typically happens, and again, when we finalize the scenarios and choose one, it's really based on what our appropriation is. So when you look at the different inflation midpoints that have happened over the time, it's really what we had funding for. We could get inflation to a certain point, but not all the way to the midpoint of the year. And then kind of bleeding into your next question on the base cost report period, I will note that there is a statute that requires us to use the most 3 current years of cost. Now that statute is subject to appropriation. So we always look at that scenario of what the most 3 current years of costs would look like, and look like with that full inflation, to see how, if we are within appropriation or not. So the years that are identified in red, going back to 2009, are the years where we were able to use the most 3 recent cost report years at that time. And in the other years, there may have, for example, last year, I believe we just rolled forward 1 year. We didn't use the 3. We were not able to use calendar year 2020, but we were able to roll forward 1 year closer, and then adjusted inflation to 3/31 of 20 within the appropriation we had for fiscal year 22. So does that help a little bit, Haley?
Yeah, it does. And then my final question is kind of a little bit to what was previously mentioned about the rates for facilities. They can change every 6 months. Can you also speak to the fact that if a nursing facility provider, what have you, has a survey to where they have deficiencies or civil money penalties or anything, that rate can also be negatively impacted? I know it's much more complex than that, but if you could give kind of a basic summary for everyone to understand too, please.
Yeah, sure. So that's a piece, we have add-ons to the rates. So the rates are set, and then there's add-ons for inflation, or not inflation, add-ons for incentives. So there are incentives in our rate setting process, and we would need to do some more digging to give you an overview of those. But those incentives are added on based on information from the cost reports. If there's incentives around staffing, turnover, we have the PEAK program. There's incentives tied to where facilities are in the PEAK program. And yes, there's also a process where if there are certain deficiencies at the facilities, that those incentives are impacted in the rates as well, and removed or reduced from the rate based on the survey finding.
Okay, thank you.
Sure.
This is Christina with Johnson County. In regards to your last statement of the rates may be removed or reduced if a deficiency is found during a survey, is it not also accurate that they may be fined if there's a deficiency?
Yes, and I can't speak to the details of the fine process, but I believe that is more driven by CMS and the CMS at the federal level on those fines. But we can get you some more information about that.
Yeah, I would really appreciate that. Thank you. To have an understanding of if the facility, and I'll give you some context of where my mind is going, is if a facility has a deficiency and the deficiency occurred due to lack of staffing, but the lack of staffing may not necessarily be the facility's fault. It may be, or the situation we find ourselves in for today example, where everybody has a lack of staffing. I feel like we're penalizing facilities and therefore penalizing the employees at the facilities, if I'm understanding that process correctly. And perhaps, I'm sure it's much more complex than that. I'm looking at it from a very lack of knowledge, I'll say. So, but is that a safe assumption that there could be kind of a double penalty there?
Correct. So in the case of a serious deficiency, the facility could face what's called civil monetary penalties that are directed at the federal level, as well as losing their incentive or a portion of their incentive from their rate. Correct.
Thank you for clarity.
Thanks. Any last questions for Brad? And I think if we have others as well, if the group has others, or maybe after you've had a chance to sort of think through, and we'll send out these materials and post them on the site for the working group as well. So if you have any follow-up questions, I'm sure Brad and Dan would be happy to respond, and we can get those either directly to them or you can correspond with them as well. But anything before Brad has to sign off? Okay. Well, thank you very much, Brad and Dan. That was, I think, very helpful, and I think really good questions that folks had to help set sort of level set understanding of the rate setting process, and then sort of the different rates that the unit issue for HCBS can always be a confounder when people look at those. So one thing we might follow up with you on, and maybe we could just send to the group separately, is some of those, ensure that we mark which ones are 15-minute units, or if there's a daily rate, that sort of thing, so that there's clarity for folks.
Yeah, I will see if I can get that added to that chart and send that back to you all.
Great. Well, thank you very much.
Yep, thank you all. Take care.
You bet. Okay, now we're going to move on to the next part of our agenda. And what we're planning to do right now is look at some of the recommendations that you all who are on the task force and others who are on the task force had discussed at the task force level, and that then were either assigned out to the workforce working group or subgroup, or there were a number of recommendations that had been discussed that weren't specifically assigned. So we asked all of the co-chairs of the three working groups and the two working groups in this subgroup to look at them and sort of volunteer or sign up for them. So we'll show you the list of the ones that come from the task force. We did some work with the co-chairs to group them. That's the document that you received yesterday, if you've had a chance to look at it. So those aren't recommendations that the task force has had. Those are recommendations that came up during the task force meetings that were proposed by members of the task force. We tried to group them into some buckets, but there's others as well. We're going to take a look at them, see what kind of discussion it'll spark, and then also help prepare us for the next meeting where you'll be working on either refining these recommendations or adding to them as well. So, Haley, anything else you want to add before we dive right in?
Nope, let's jump in, please.
Okay. So y'all see the screen? So there's a document that the Kansas Legislative Research Department keeps, and it keeps track of it for the task force, and it has a full list of all of the recommendations or language that have been discussed. We've done some sorting. Basically, we added a column for working group assignment. Assignment, in most cases, the task force didn't specifically assign, so some of this is also the volunteering for, or we think it kind of makes sense here with this working group. The meeting date proposed, all of these, I think, workforce related, were in the December meeting. And then it says, committee member recommendations. I think that's the task force who had discussed those recommendations, the task force members. And then in the meeting notes column, I just started to add some ideas potentially of how these recommendations might be bucketed, but we can talk about those as well. So the buckets that we had talked about with the co-chairs were funding, which we'll go to in some of Brad's comment. Brad and Dan's presentation definitely will deal with that. There are some of the funding related and finance related recommendations that are in another working group B as well. But given some of the topics that you all talked about in the SWOT analysis, there may be other recommendations that you add that really that information will help inform. We had licensing. There was one of the recommendations is about a scope of practice, for example, for advanced practice nurses. And then there's this, maybe Deborah can talk about these two as well. It's not exactly licensing, but sort of oversight, grouping of recommendations about oversight for temporary staffing agencies. Then we had a group that are about expanding workforce and then alternatives, both the alternatives in the current system, and then a career ladder, which I think is will be an interesting discussion and one that we can really spend a lot of time in one meeting probably really digging into. So, but first, maybe it'd be helpful just to see if anybody had any thoughts or questions if you had a chance to review these. Otherwise, we can just start to go down the list and see if you all have any comments or how you'd want to group them, information or other information you would like to have as we start working in your next meeting to really start characterizing and refining these recommendations. And after this, then we'll also go through and look at our SWOT analysis from last time and see if there's anything you'd want to update and show you a tool that we'll be using between meetings to help you all develop other recommendations that you might want to do. Does that make sense? Okay, with that, Deborah, I don't know if you want to speak to this, but one of the recommendations that have been discussed was oversight of temporary staffing agencies. And there were two, both you and Linda had proposed language which is pretty similar about establishing a registry, creating basic regulatory framework, upper limits on charges, etc. So is there anything you'd like to speak to about this or provide some additional context? I think you're muted. There we go.
Now I'm not. So the first and second potential recommendations are the same, basically. There was a bill in the House Children and Seniors Committee a couple years ago that would have done this very thing, established rudimentary oversight of temporary staffing agencies, including having a registry. We don't know. There's no central entity that collects the names and the owners or the locations of these agencies. And as you might imagine, they have proliferated exponentially in the last 2 years. We did a survey of our members, us and Healthcare Association. We got about a 50% response rate, and there were nearly 60 temporary agencies that they listed. And there's a lot more than that, but 60 and 11 or 12 of them are out of state owned and operated agencies. So there's no central repository of any of this information at the state level. We'd like that. That would be part of the bill. There's going to be a hearing on this bill, I think, week after next in Children and Seniors. Just FYI, we don't have the date yet. But I know our Chief Advocacy Officer has been working with the chair there to get this on the docket for hearing. And
Deborah, can I ask a quick question?
Sure,
What's the bill number? You may have said it, but I wanted to write down the bill number.
We don't have a bill number
Oh,
yet. It was just introduced yesterday. I mean, a couple of years ago, we had a bill number, but
right.
It's going to start over. So
okay,
there's no
we
bill.
We can pull that once that's available. We can also send that around as part of the meeting materials to the group.
And the date of the public hearing. One of the things that in our very free market centric political environment that is will be probably the most controversial is establishing caps for what staffing agencies can charge. It is in the bill. We do want that. And there are a couple of states that have that kind of regional caps based on, what the average wage is for a certain kind of worker in that region. And I think our cap is 150% in the bill itself. But that's going to be the highly controversial piece in our conservative legislature. So if we want all of this, but and some regulatory oversight of some sort, because there's all kinds of unscrupulous, unfair business practices going on, contracts that are not being followed, and ultimately, it's the resident of the adult care home or the hospital, for that matter, who is at risk through these unscrupulous practices of temporary staffing agencies. So, I could talk more, but
I think that's helpful. Do others have questions, or is there any research that we could do between meetings? It sounds like probably there will be some information available then at the hearing as well that we could provide to the group. But you mentioned other states, so one thing that might be helpful is to understand how other states approach this.
Yeah, a lot of states are looking at this kind of legislation right now. The one that just comes to my mind right now that has this kind of legislation, and the bill that's been introduced here in Kansas is patterned after is Minnesota. And they've had this in place for several years. But there are other states that are looking at it.
Deborah, this is Christina with Johnson County. Have you heard what Texas has done Are you aware of anything Texas has done recently?
No, other than the state is paying for temporary staffing agency. And thus the negative consequence to Kansas is that ours who would work here are going to Texas because they're getting paid there, whatever fees are, you know.
I was speaking to a colleague as well, and they said that the other side of that Texas has done is if an employee that lives in Texas wants to work for a temporary staffing agency, they have to leave the state. They can't work for a temporary staffing agency within the state. And I don't know if that, I didn't know if you had heard that or if it was effective or.
I think I've heard it. I don't know whether that is that actually in law now?
I don't know if it's in law. I heard it at a conference. I don't know.
Yeah, I do not think it is in law right now, but there's a lot of legislative, there are a lot of initiatives and bills that are being introduced throughout the country on this. Yeah. We feel like ours is a core, basic, whatever, but we definitely suffer in Kansas from the phenomenon of people going to work in Texas.
So true.
This is Camille, long-term care state ombudsman, and we support anything that is we're looking at that increases the quality of life and quality of care for residents. I actually do think that this would be an opportunity for those staffing agencies to tell us how they were able to gain a workforce while our long-term care providers were losing them. So what are they doing to entice that workforce to work for them? And because we do hear from those temporary staffing, those agency workers, we hear in our office, but I think coming straight from them, the workers themselves, them telling us, I think would be a good idea.
This is Kelly. Oh, sorry.
Go ahead, Kelly. I'll tap in after you.
Okay. This is Kelly Summers with KSNA. Actually, I had a call with staff with Representative Sharice David's office last week, and I have another one on Monday. And we are having conversations right now on what could be done on the federal level, not only with travel nursing, but with these agencies in particular too, to do a national, how we would actually regulate this across the country versus leaving it up to each individual state right now. So I do appreciate that we are able to have these conversations. I appreciate that they reached out to me. I've also talked about it with Senator Moran's office 2 weeks ago. So we are having these discussions because we need to keep in mind that when you have agencies come in, I don't know what the fee that you're paying, but that's a fee that actually could go to direct staffing versus bringing in your agency, which is very important because your direct staffing are the ones who really have the experience, because this is a specialized area of care for our seniors. And so when you're bringing in a temporary staff person from those agencies, normally what I've been told is they basically know nothing about long-term care or care in the community. So I just wanted to put that out there so that everyone knew the vantage point and what I'm doing on this part so far, and share with you. And so if you ever want to provide me feedback, if you want me to address any issues prior to Monday, Carrie has my email and you can reach out when I talk to Sharice Davids.
Yeah, our national associations too have been putting in requests to, I can't remember which federal agency right now, but one of the federal agencies to do some price gouging investigation. And likewise, the long-term care associations have asked our state attorney general twice to do an investigation of price gouging and unfair business practices of temporary staffing agencies. And at this point, they have not been so inclined, but that does not mean we will not keep working on that angle. So there are many, many pieces to this big monster elephant, and we have done a lot of investigating, a tremendous amount of advocacy, and you know, if you want to talk to me offline, I guess that's permissible, maybe not. Related to the bill that is being introduced, or anything related to that. If you'd like a copy of the summary of the survey we did, I can share that with you.
That'd be great, Deborah.
Yeah, I'll send it to you, Carrie. Is
Okay.
that be the appropriate person?
I think so. So when as I think Jesse gave us the update in our first meeting about sort of open meetings and so on. The idea is certainly
right.
Individual conversations, one-on-one conversations, just like you would have in a hallway. That makes sense. It's when there's any potential serial communication where you talk to one person who talks to the next person who talks to the next person that could have an impact on open meetings. So as much as group conversations should be done in these open forums. So, but we can send out, if you've got information to send or questions, we can send that out to the group, because we also post that information so that it's available for the public as well. So that would be great. If we could send that, we'll also post that and make that available. Just make sure you remember that if you're sharing information, it will be posted as well.
Yeah,
On
I
the
think that's because the almost 60 agencies are listed by name.
Mm-hmm.
The ones that the respondents to the survey said they would never, they no longer contract with or will not contract with due to quality issues. Those are listed in the survey. So, so it may not be appropriate to share that level of detail with the public at this point. I'm just saying.
Maybe a summary. I think something like summary would work. Great.
Yeah.
Carrie, this is Leigh Chaffee from Brewster. Can I make a comment about our recommendations with temporary staffing agencies?
Yes.
I would just like to maybe, I don't want to say the word caution, but I do think it's very important to tackle this issue, but I think it goes back to what Camille said in her introduction. If we throw our entire focus on this one aspect, the bigger picture here is nursing homes don't want to rely on staffing agencies at all. We would like to get to the point where we don't have to use them. And so we need to keep that in mind as we're working through this. I do think it's a very emergent, present issue because it is something that can help care for our seniors. But I just want to make sure we keep in mind that an overall goal would not just be to be singularly focused on this is how we staff the ability to care for seniors. Thank you.
Did I capture that correctly, Leigh? Basically, but this is important, but the context is like really the subject of this entire work group about workforce. It's important to tackle, but there's an underlying cause of why facilities are using temporary agencies. That's really many of these other recommendations should be getting at. Is that what you're going for? I want to make sure I captured that right.
Absolutely. Thank you, Carrie.
Thank you. Okay, well, in the interest of time, let's move along. I think we've got a lot of information to share, and we'll get some additional information. So when we start working this recommendation, or expanding upon it, or modifying it, or coming back with feedback for the task force, we'll have more information to do so. I think that covers the first couple. Deborah, similarly, I think there's the next two are related. This is reauthorization of the trained temporary nurse aides. Is anything in the executive order and some of the legislation that's going through the legislature right now? Is that something that and is that still during the public health emergency specifically, or does that extend beyond PHE?
Yeah. So the bill passed the House, 2477.
Mm-hmm.
The bill is on the docket to be debated and passed by the full Senate today. They passed different versions with different end dates. Both of them do have end dates. So they will go to conference committee once they pass and kind of hammer out, which end date they want to adopt. So they've moved very quickly because, of course, the governor's executive order was only lasts 15 days, and that ends tomorrow. That 15 days is up tomorrow. So
Deborah, is there anything in, oh, I'm sorry, go ahead.
Go ahead. No.
I was just wondering just the timing and thinking about this work or the subgroup's recommendations and the timeline for the report is going to be, developing those recommendations, you'll be sharing with the task force. Is this likely to be resolved? So not as relevant. Okay.
Yeah. It's going to be resolved here in the next couple, 3-4 days for sure.
Okay.
Yeah.
So potentially these two just come off the list as
drop
done.
off. Yes.
Yeah. Okay.
This is Christina with JCCC, and a sideline on the temporary nurse aides that we found. Oh gosh, I want to say it was March or April of last year. Is nobody was tracking who those temporary nurse aides were and where they were working. So that became an issue last year when the original emergency order was going to expire, that all of a sudden everybody was in crisis because, we had to get these nurse aides certified as actual CNAs, but nobody knew who they were or where they were working. So that I agree that, the authorization in the bill and everything will most likely go through. However, we may want to keep something on there about them just because now there's going to be a tracking issue of who are they and where are they working.
We track their use. Yeah. The latest thing I saw was that during the first executive order in which temporary aides were authorized, there were about 12 or 1,300 trained in the state. Left, and it's in the hands of the employer to keep track of who they're employing in that capacity and, do the competency checklist and do the supervision and so forth. And since this new executive order, which is 14 days old right now, there have been 65 additional people who have taken the class. But you're right. There's no central repository at the state level of where or if these people who have received this training are working. I know some are working in hospitals.
Thank you. Why don't we keep that on the list then as sort of that issue of like what's happened there?
Yeah, developments.
It may be less about this reauthorize and more maybe you could evolve that into what we learn from that. Okay.
Yes.
Great.
I think that's good. Yeah.
Camille, the next couple are some recommendations or proposed language that I think, at least per the KLRD document, had come from you. And one was talking about having the MCOs exploring alternate supports to address workforce shortage. So, and you can speak to that. And then you also, and I'm not sure it belongs here exactly, but it relates to self-direction, is better advertising the worker matching registry that's used by all three MCOs. Do you want to talk about either one of those? And if there's some information or maybe would this work group like to hear from MCOs or from the state, from the Medicaid agency about how they would approach this, or what would be helpful?
I think the MCOs could probably speak to this a little bit, but I'm going to, my underpinning of this is that those are person-centered practices. The MCOs have their own teams of trainers about person-centered thinking and person-centered practices, and we are willing to bring some in too as well for the industry, and that they do that as a natural course, that they will look at what people truly really want, and so we're going to provide people the services that they only really want and need, and only have to pay for those services. And as we have a aging population, or a population is going to require more things, we're going to have to be able to do more with less. That's probably the direction and model that we also need to look, is that we are providing them with what they only truly want and need, and so they can talk to that. They have the ability, and they do that when they do their service plans. So I think maybe they would be someone to talk to about that.
Who else? Are there others who could, or
honestly, we could have we have folks from Charting the Life course. That's a national Yeah, Charting Life Course would be wonderful to come talk to us, honestly. They would come do a short presentation. We have ambassadors. Actually, we have trained people in the state, but I think that having someone from UMKC would be very beneficial.
Mm-hmm. I think you brought that up in the last meeting as well, so we can have that as we talk about that recommendation and sort of in that. It maybe seems odd to group that with expanding the workforce and alternatives, but it really is like other ways to address workforce is the, I think.
And even our workforce that exists, if they understand those concepts, they can do what the person wants and more for the person in a person-centered way themselves, and be more productive in the workplace.
Mm-hmm.
It would pay in the nursing homes to do it.
How about the next one about the worker matching registry?
Well, and I think I got my name on there because I didn't know it existed, and I thought it was really a neat thing, and that we should figure out how to make that be marketed and expanding the ability to use that better. I didn't know about it, so I'm not sure I can speak to it.
Does anybody here on the work group have information about that or on the registry?
Carrie, this is Haley Ordin with Kansas Adult Care Executives. Camille, was it Jan that recommended that? I feel like it was somebody sitting to my right, and it was either you, Jan, or Janice.
It may have been Janice, and it may have been Janice. Now that you say that, it's kind of ringing a bell.
Okay. Well, we can follow up. Dan, maybe I can follow up with you, and we can see what's available and provide some information between this meeting and the next one about the registry. Sound good? Okay, we will work with dads to. So you want to learn about it, and then say, hey, let's make sure it's available to folks, and learn how it's made available to people. Great.
I'm familiar with it, so that would be great.
Yeah. Okay. Well, a big one that this group is in a lot of your many of your SWOT analysis sort of opportunities were kind of focused around career ladder. So Jamie, and I know that this is a very specific idea within career ladder, was tuition grant program or a loan repayment program. Do you want to speak to that a little bit? And then we can also talk about anything else folks would want to have us get some information about that we could bring to the group for when you really dive deeply into career ladder recommendations.
Sure, thank you. Jamie Gideon with the Alzheimer's Association. And my idea came from an Iowa bill that's currently pending. They have 3 separate things to help encourage. This is more of a long-term answer to the workforce shortage. And this is specifically aimed, and it could be aimed at additional ones too, but this is the direct care worker programs that they have. The first one is the tuition grant program. And again, it can be lined out any way you want, but this in Iowa, they have it to help with an entire 2 years for the degree. And they pay it kind of, I looked in different states, and other states have it differently, but in Iowa, it's 50% of tuition through this grant. So that's like the first part of it. The other part of the bill, they have it all in one bill.
Oh, Jamie, I don't know if it's just me, but you're cutting out a little bit. Is she cutting out for others? Yeah, I think maybe.
Let me stop my video. Just a second. Okay, can you hear better?
Yeah, I think so. And I don't know if it was cutting out or if you're moving away from the mic. I couldn't tell which one it was.
Okay.
But, yep.
I will make sure I talk into the mic. Anyway, the other part that they have in here is the besides the grant program is a loan repayment program for direct care workers. And that they talk about it will not exceed 20% of the loan. So again, that number can be whatever is decided, but that's what Iowa is using as part. And there's all different conditions listed on there as well. But that's just another idea. Also, the last thing to mention that I hadn't mentioned before was the tuition tax credit is also in the same bill as an idea. And so that's just another additional thing that can be added. As part of that, they have so the tax credit equal to 65% of the amount of the payments made by the eligible student taxpayer. So it's quite a bit of that tax credit, 65%.
Mm-hmm.
Anyway, just some ideas to address long term. We could, and all can be in the same bill too.
Jamie, if you wouldn't mind, if you want to send us that legislation, and
Yes.
And then we can send that send it around to the group and then post it as well. So good, great. Other thoughts or questions about sort of career ladder, Deborah?
Oh.
Deborah, I think you're muted.
Yeah. So certainly some long-term care providers have had career ladder programs for many years. So it would be kind of a question if we're talking specifically about career ladders, which Jamie's advocating for a broader package of stuff. It would be interesting to know what some of those are. And I don't think she would be recommending that we do a universal career ladder program that is required by state law or regulation for everybody. But because I don't know that I'd be in favor of that, just saying. We also have the Kansas Nurses Scholarship Program that is already in place, that people who are pursuing nursing degrees, be them associate degrees or bachelor's degrees or whatever, can get a certain amount of their expenses, their tuition reimbursed, and in partnership with an employer, ultimately, of that nurse. And there is a split, like there's a rural rate that employers have to pay back, and there's for urban, there's a different one. So that is in place. I don't know. It would be interesting to know how that's actually going out in the real world.
Kelly? Kelly's got her hand up. So what do you say to that, Kelly?
Well, I actually going to talk about, if you don't mind, mention a couple things regarding this discussion. Kelly Summers, KSNA. The scholarship program, when you were talking about employers offering that scholarship program, where it used to be, if you went to school for RNs, if you went to school, then if you promised to work for that employer for, let's say, 2 years and signed that whatever the contract was, it was a great draw for a lot of the nursing schools. I have not heard it. Actually, that went away a long time ago. And so this whole nursing scholarship is not being utilized. The cost of nursing school is exorbitant. And this barely touches on it at all. To me, it's an absolute not a solution moving forward.
It's still in statute. So
right.
But more regions to report to this group on it.
Right. And I appreciate that, but I can tell you there's a lot missing in this. And so I'm always happy to discuss that further. The other thing is that on the national level for 30 years, we actually had a grant program federally. So Kansas was able to utilize this. It went away about 4 or 5 years ago. But we had it for 30 years, and that was a grant program on the federal level that reimbursed nurses. And so I would always like to look at this from other levels too, that reimbursed nurses if they went to work in an underserved community in Kansas, which I think that's basically every community in Kansas right now. But actually had where they would repay their student loan up to 65%. Personally, I had 65% on mine because I went and worked for several years in an underserved area in Kansas. It was an amazing opportunity to pay back those student loans. It's something that the Kansas State Nurses Association, the American Nurses Association continues to lobby for, but it gets through the House every single year, installs in the Senate. So I just wanted to throw that out there because it's a federal program that should be funding our states to help with staffing too. And it's not happening anymore. And we had it for 30 years. So I guess if you look back 4 or 5 years ago in long-term care, I'm curious regarding data on where you were on staffing versus when that went away. So sorry.
Can I ask a question on that?
Yeah.
Sorry, this is Haley with Kansas Adult Care Executives again.
Yeah.
So is that something that there's federal funds? Would the state need to put in anything for like pulling that for like matching contributions or anything? Or is it just like it passes the House and just always stalls in the Senate,
Right.
but it within our power that we can bring on board?
It was not, when the 30 years when it was in place, it was not a matching program to my understanding. And I'm sorry, I'd have to go back and look at it all again. Historically, I can tell you on the national level, I have advocated for years, because as I've said earlier, we knew the problem was staffing, and we knew there were going to be huge issues for all areas, for myself, where nurses work. So I never want to focus just on hospitals, because we have to remember it includes this task force and this group completely, and impacts you. So the fact that that went away is huge for everyone in this group moving forward. So we continue to advocate for that. Like I said, every year it goes to the House, stalls in the Senate. And that's what's been happening. And I know that, I think it was 3 or 4 years ago, that funding was actually even took out of on the federal level regarding nursing. Now, and I have to research this more, in the Build Back Better package, and I'm being neutral here, bipartisan, but in there, in that package is something regarding funding for nursing, funding for nursing period for us in our state too. So I just wanted to mention that, if this is something to look forward to.
Kelly, we'll follow up with you too to get information about the federal program, to figure out whether is it not currently funded, or did authorization expire? So, and then whether there's, any of the plans have a state policy component as well.
Yeah,
So,
I
Ernie,
have to
saw
go
your
through,
hand.
I think, every year, and then it just stopped. So
We
thank
have,
you to indulge me. I'll
no worries.
talking.
We have 6 minutes left, so we're not going to be able to get through the last two here, but we'll talk about our strategy here in a minute, and then we'll talk about our next meeting. And we do need to end at 10:30, because I think somebody else needs this virtual room, a committee. So, but Ernie, I saw your hand. Is there anything you needed real quickly?
I just had a quick question. I think for Deborah, she was talking about the career ladders. Do you know that you said some nursing homes did, some didn't, or some facilities didn't? Do we know which ones might and which ones might not, or if we could create some sort of template for homes or facilities that may encourage them to do career ladder work?
Yeah, I think during the public health emergency, it might be hard to get that accomplished, just saying. The one other thing, there were 2 things I wanted to say on this topic. Kansas registered apprenticeship program for long-term care workers. That is a thing. Leigh Chaffee's organization was one of the first in on that. I don't know if she's still doing it or not, but that is actually a career ladder with pay adjustments, that coincide with that for direct care, frontline, paraprofessional type workers. And then also we have the CMP fund at KDADS that could be used for some of this stuff that we're talking about. There's not billions of dollars there, but that's something to be explored as a potential pot of money. That's all.
Shawn, I see your hand. I think that's the last hand, and then we need to go on to the next business.
Yeah, real quickly on this, it'd be good if we could hear from the Board of Regents on the Nursing Service Scholarship Program, how much it's utilized. Obviously, it does have some flaws, but what recommendations could be forwarded on to make it better, more highly utilized, more useful, etc.
Thank you. All right, thanks everyone. And I'm sorry we didn't get a chance to have sort of that initial discussion. So we'll send some follow-up questions about the recommendation about rates, which we heard about earlier today, right? So for the FE, the frail elderly, physical disabilities, and brain injury waivers, all of which can serve older adults. And with the idea, this was Annette Graham, who's a member of a different working group, to require providers to pass rate increase to direct service staff. That's an interesting wrinkle. And then, Ernie, I think maybe in the next meeting we can give you an opportunity to talk to about collaborative practice, about the independent practice for advanced practice nurses and the relationship to long-term care. So we don't have time to do our update on and ask you to update the SWOT analysis based on what we've talked about, but we will send you a tool that I will ask Emma to share in a quick second between this meeting and your next meeting, which, if I have it correct, is February 17th, in a meeting where we'll be working on refining recommendations. But it also means maybe the opportunity to develop some recommendations related to those issues that we've talked about, and related to what your strengths, weaknesses, opportunities, and threats analysis had done before. This is also an opportunity. We'll send it out and you can say, oh, wait a second, something that I had as an opportunity got put into threats accidentally, so can you move it back? So we'll ask you to review it with that eye. But I'm going to ask Emma, I have to stop sharing in order to do this, to give you a preview of the tool that we're going to send out to you to help prepare for the next meeting. And then it's the tool we'll be using in the next meeting or something like it. So there's 4 pages of this, and it will be basically using that strengths, weaknesses, opportunities, and threats analysis to help think about recommendations. So on each page, there's 2 of the components. So you think about that 4x4 quadrant of the opportunities and weaknesses and threats. So an example here is a page of where we'd ask you to look at opportunities and weaknesses together and then help maybe generate some thoughts about strategies, policy recommendations that could help overcome weaknesses by taking advantage of those opportunities. And then scroll to the next page, threats and strengths. Where's a strength that can be used to avoid or minimize or mitigate a threat? So it's a tool. You can certainly think about other recommendations and you don't have to force it to fit into the tool, but it is a tool that hopefully will help us make sure that all the things that you have been talking about and thinking about, we have the opportunity to potentially develop a recommendation about as well. So that we don't leave something on the table that everybody talked about, but it wasn't in some of the language. And this is hopefully an opportunity to be able to remind you all of the work you've done so far. And we'll keep updating that. And if we add other opportunities, threats, weaknesses, strengths, we'll add those to the tables as well as we work. That makes sense? It looks pretty daunting, but it's actually just something that helps you think, organize thoughts to be able to work on these recommendations. We will send that out, but we'll also be using it. So you're not required to send it back in advance or anything. It'll actually just be sort of a worksheet to be able to work between meetings. Thanks, Emma. And with that, I think we are at 10:30. Any last thoughts or any last questions for folks before we sign off for today?